This unit deals with submodule 12 of the Diagnosis 2 module and is titled Oral Pain, Interpretation, and Localization. One of the most challenging jobs you're going to have and tasks in the field of dental practice deals with the identification of a poorly localized pain situation in a dental patient. And you have to have an appreciation of the many factors that enter into this business of pain interpretation by the patient. For it's a guide by which you can well follow with sequential steps in the localization of these conditions. Many of your patients you're seeing for the first time to come to see you because of a complaint of dental pain. Many of them can't tell you which tooth is hurting. They can, in many instances, tell you the area. Sometimes they can't even tell you which arch, but will complain that they have a toothache on the right side and they're not sure which tooth is hurting. This is where you put together all of the knowledge you have and capabilities you have as a diagnostician to differentiate the pain source. Now, pain is a very personal thing, and its interpretation by the patient is very real, and you must accept the fact that they are experiencing pain when they complain of it. But you've got to know a great deal more about the overall picture of pain than just this. First off, you need to appreciate the fact that pain is basically divided into two major groups: a superficial type, which is simple to localize, and a deeper type, which is most difficult for the patient, or for you for that matter, to localize. Now, superficial pain is a variety, say, that might occur with an injury to the finger, and because of experience the patient can very simply localize it. A superficial type pain in the dental structures is that which involves the gingiva or the alveolar mucosa. This type of pain, periodontal pain most often, is easily identified by the patient. Now, the deeper type, such as visceral pain, is most difficult for the patient to localize because of their lack of experience. Now, in dental diagnosis, pulpal pain is considered a deeper type of pain and is of the variety that the patient has little experience with and can give you a very poor assist on localization. I think that by and large, the majority of complaints of pain that's going to be coming into your office will be of the pulpal variety. But let's consider the number of types of pains that the patient may complain of, and the approach, the systematic approach which you need to use in the identification and localization of these pain phenomena. In the pulpal pain, which constitutes the majority of complaints of dental pain, if you had to list them numerically of those coming into your office or into your practice, pulpal pain is the most common, and is most often associated with carious lesions, defective fillings, or injuries to teeth. Periodontal pain is that which arises within the periodontium, the structures, the support apparatus of the tooth. This includes the gingiva, now, the periodontal fibers, the cementum, and the alveolar bone. In most instances, it's very simple for the patient to localize this type of pain. A fourth variety is a referred pain. Now, pain that is referred from another structure, an adjacent area, is oftentimes interpreted by the patient to be of dental origin, and you have to differentiate between the two in determining if this pain is of odontogenic basis, of tooth origin. An example of this would be a maxillary sinusitis. Infection, tumors, disease of the maxillary antra is often interpreted by the patient as pain in the bicuspid area or even the first molar area. Rarely does it affect the structures as far forward as the cuspid, lateral, or central incisor, because the anterior wall is distal to the cuspid in most patients. But pain phenomena within the maxillary sinus, because of the proximity of the roots of these maxillary bicuspids and first molars, is very often interpreted as tenderness, pain, affecting the dental structures, and the patient will come to you because of the discomfort. It's your job to rule in or rule out a dental basis for their pain. The fourth variety which we should consider is the psychogenic pain. Now here you have great advantage over the patient, and your ability to determine whether or not the pain is of psychogenic basis or of dental basis is going to be based upon a exacting, deliberate, careful evaluation of the dental structures to rule out causes as being dental. It's going to be enhanced by your knowledge and understanding of the nerve pathways, the sensory nerve pathways. A striking example is the patient who comes to you and tells you that the pain originates in the molar area, always first thing in the morning, and gradually travels all the way over to the left molar area. Well, you know very well from your knowledge of anatomy, of neuroanatomy, of physiology, that this just can't happen. The other factor which involves so often in the psychological or psychogenic-based pain phenomenon is the fact that when pain has basis other than psychogenic, it will awaken the patient during a night. But the patient who's suffering from strictly a pain phenomena of psychogenic basis will tell you that they can sleep through the night. It doesn't bother them in the evening. Now, as far as the approach which you should use in pain identification and localization, first and foremost, you need a good history. Now, you should do this on all patients routinely anyway. But when you're trying to play the detective in diagnosis and run down the source of a painful situation not readily identified by the patient, not localized by the patient, then let's take this history. Let's find out all we can about what causes the pain. And your knowledge of dental diseases, oral diseases, if you will, is the basis on which you can interpret this. If a patient, for example, tells you that they're having discomfort, and they can't tell you which tooth, but the pain occurs associated with the ingestion of hot or cold or sweets, you immediately think of pulpal pain as a basis. This being the type, of course, that's most difficult for the patient to localize. If the patient can tell you the tooth that is involved, of course you have no difficulty in differentiating, and they can identify it because of tenderness and soreness in the adjacent areas to the tooth and point right to it. You may well be dealing with a periodontal-based pain. In the referred pain, in addition to a maxillary sinusitis, there are a number of other areas which can cause referred pain. There have been many reports of pain from angina pectoris being referred to the lower jaw. We mentioned the maxillary sinusitis, often causing the pain to be interpreted as dental pain, when in reality it's due to pathology of the maxillary sinus itself. You can have pain in adjacent areas to a third molar due to an infection and involvement around the crown of a tooth referred to as a pericornitis, an itis or inflammation of the pericorneum, that portion of tissue over the back section of the lower thirds, which so often occurs in the eruptive periods of third molars. This can cause pain to be referred up the angle of the mandible into the ascending ramus. Now, by and large, pain phenomena which occurs and is of a referred nature in the head and neck is referred to the joint and ear area. After we have taken a careful history of this patient's pain situation, as well as a past dental and medical history when this is a patient coming to us for the first time, then we want to do a meticulous examination. And in these difficult localization problems in dental exams and dental diagnosis, we're going to use a good examination approach, which besides careful visualization of the dried dental structures and soft tissue structures which we're going to palpate, we're going to examine, we're going to do a clinical exam for caries. We're going to do a clinical exam for periodontal problems, which may be a pain source. And of course, you're going to be aware of the fact that in many, many instances, there is a combination involvement affecting both pulpal tissues and periodontal lesions in the so-called combined lesion phenomenon. We're going to take good röntgenograms. We're going to evaluate pulpal vitality response by pulp testing. And this, of course, has to be interpreted with you, paying careful attention to not just the fact that you get a vital response, but the type of response you get. The type of reaction relative to the same tooth in the opposite arch. The type of reaction that has to do with the continuation of discomfort when you've stimulated a tooth electrically or thermally, when you have removed the irritant, remove the electric pulp tester, remove the ice, remove the heat. If the pain persists for a matter of seconds instead of stopping immediately, then of course you realize you're dealing with a pulp situation that's not vital, not healthy. You may have some vital tissues in it, but it's under the process of degenerative change. We're going to use percussion. In most instances, we use the cone socket handle to our examination mirror, our dental mirrors, and we tap in the long axis of a tooth to determine the presence of an inflammatory change within the support apparatus. And so often you will have this inflammatory reaction in the apical zone, which may not show in the röntgenogram, but where there is an extension of pulpal inflammation into apical tissues, percussion will reveal the presence of a tender tooth, a tooth that requires further investigation. There are times when we must rely upon anesthesia to pinpoint or localize the area of pain. So we'll add anesthesia to our list. For example, if all has failed in your attempt to determine the source of pain, and the patient is sitting in your chair and complaining of discomfort, we may block the teeth in the mandibular arch with local anesthesia, and if the pain stops immediately, we have now localized the pain source to the lower jaw and can concentrate our efforts at a subsequent period in localizing it there. If, however, you give the patient a block injection, they continue to have pain, you realize then that you're dealing with pain in the opposite arch. There are times when it is most difficult to isolate the individual pain source, and this is usually a pulpally involved tooth, for you may have, in such a condition, an incomplete fracture of the crown. And these present a real diagnostic challenge, which we will go into in the next study unit. When this still has not verified the presence or absence, but you have localized your pain source to a very questionable tooth, there are times without the benefit of anesthesia that we do what is referred to as a test cavity, where with a very small burr we will penetrate through the enamel into the dentin to see if we get a reaction from the patient as discomfort. If we do get discomfort, we stop immediately. We realize we're dealing with a vital tooth. These things should be done in sequence. In your clinical situation, your professor will work closely with you in the diagnostic problems and follow this approach in attempting to determine the source of the pain, whether it is a pulpal, a periodontal, of referred or psychogenic basis, and its localization as to arch, then as to tooth. Once the determination has been made, you proceed with your therapy for, number one, the relief of pain, number two, the treatment of the individually involved tooth to preserve its integrity in the arch, if at all possible. It is through the use of a meticulous, careful approach and the application of all of the knowledge that you have in basic and clinical sciences, with this correlation, this integration of knowledge, that you can follow methodically the approach to localization and interpretation of dental pain when it becomes a challenge.